All right. Well, we're coming up on 11 a.m. our start time, so I'm going to go ahead and get started with some housekeeping. My name is Chris Gaffney. I'm the executive director of Parkinson's Support and Wellness, and apparently most of you are familiar with our organization because you've shown up here and seen the invitation to our monthly educational seminar that we call PDEDU. And today's program is the basics of Parkinson's, and that includes a peer-to-peer conversation as part of our presentation. Just a little bit of housekeeping. We'll ask everyone to mute their microphones during the presentations. We will make questions available through our chat box. You may notice at the bottom of your screen, your Zoom screen, a box that says chat. If you click on that, it will open it up, and you can type in any questions that you may have throughout the program. Typically, our program goes for an hour. Today, it's an hour and a half, since expanding the limits of the program here. And we will take those questions. Maureen Gardner will moderate the chat and pass those questions along to our presenters. Maureen, most of you probably also know Maureen Gardner. She is head of our program committee at Parkinson's Support and Wellness, as well as being the secretary of our board of directors. And the program committee is responsible for these PDEDUs. The committee works hard to come up with topics and speakers and make sure that this is actually one of our most popular programs. And with that, I'm going to go ahead and turn it over to Maureen to get us started.
Good morning, everybody. Thanks for joining us. We're really fortunate to have Dr. Jorge Patino with us today. I'm not going to read what was on the website, his bio. I just want to say he is smart and careful and very engaging with patients in clinic and kind and supportive. And I'm looking forward to this presentation because I'll probably learn something new as well. So Jorge, thank you again for doing it, and you go for it.
Well, thank you, Maureen, for that. I have to accept that during these 6 months, I've learned so much from Maureen too. So this is a wonderful collaboration. Everyone in the team. So we all learn from everyone a little bit. So thanks again for inviting me to give this talk. When I was told to give a talk about basics of Parkinson's, I just thought of the things that we educate our patients on when they come to the clinic and things that I find very helpful patients are knowledgeable about so they can come and challenge the physician in terms of making decisions for their healthcare. So because this is always a collaboration and we want to make sure that patients have all the information they need to make decisions for themselves. So this is what we're going to talk about today. So I don't have any conflicts of interest yet. And the objectives for the talk are going to be understand why Parkinson happens. And this is with a caveat of like, no one in the world really knows 100% why it happens and how it happens, but we're going to tell you what we believe is happening. And then we're going to talk about potential genetic and environmental risk factors and also protective factors for developing Parkinson's. We'll talk about the clinical signs and symptoms and the way we diagnose Parkinson's in the clinic, learn about the therapies that are available, both pharmacologic and non-pharmacologic, for the motor symptoms of Parkinson's disease, and learn about ongoing research that can improve quality of life in patients with Parkinson's. So overall, what is Parkinson's? And every time someone comes and talk to you, they like to talk a little bit about history. And the name Parkinson's was coined after James Parkinson's published an essay called The Shaking Palsy. So he was describing patients a long time ago that in like around 1817 that they were having some slowness of movement, tremors, maybe stiffness or trouble with balance, postural instability. And that's what we know of still 200 years later of what the disease looks like. There is a a structure in the brain that is called the substantia nigra, which you can see here in the image, that hosts a group of neurons that are in charge of making dopamine. Just as a fun fact, dopamine comes from similar cells as the melanin in your skin. So that's why it looks dark, like it's stained, because it's like what gives color to your skin. So it is the same in the brain, this area that's called the substantia nigra. These neurons that make dopamine send that dopamine to the parts of the brain that we call the basal ganglia that help you move, plan movement, and that circuit or that connection is what's changed in Parkinson's disease. Now, it is only when you lose about 50% of these neurons that are making dopamine that you start manifesting motor symptoms of Parkinson's. But that doesn't mean the disease hasn't started before, because you start losing these neurons many years before. So that's when we ask our patients, have you had any changes in your sense of smell or taste? Because those can happen even 20 years before the motor symptoms start, or changes like constipation, etc. Now, there is a protein that we believe is associated with Parkinson's that is called alpha-synucleinopathy, alpha-synuclein. And you'll hear your physicians talking about alpha-synucleinopathies, meaning it's an umbrella term for different diseases that could be related to this protein that can start not working very well after the years pass. It's not necessarily toxic. It just means the protein that we're all born with that is in our brains starts not functioning the way it should because of several reasons. Now, we still trying to understand how the disease starts, how it progresses. And then in 2004, Dr. Brack came up with this system that still is under evaluation, but gives us a very good idea of why people with Parkinson's can have non-motor symptoms before they present with tremor, rigidity, or slowness. So pretty much what it shows is that that abnormal function of the protein can start from the lower parts of the brain. We call this the brain stem. I like to tell my patients, imagine that the brain is like a broccoli. So you have the broccoli like leaves, and then it's the stem. That is exactly the same in the brain. So the brain stem is hosting different functions related to non-motor features, such as trouble changes with sleep or constipation, and especially some functions of what we call the autonomic nervous system. The autonomic nervous system, as its name says, is autonomous. So it controls your breathing, your cardiac function, your gut motility, your stomach emptying. So those things can change before you develop motor symptoms in Parkinson's disease. And if you look at this one here, is the olfactory bulb. So changes in smell or taste can also present many years before the disease starts or the motor symptoms start. Then this progresses upwards towards the higher parts of the brain. And that's when you start seeing that the substantia nigra, which is here, starts being affected. So your patients develop motor symptoms. And in later stages, it can go up to the higher parts of the brain that we call the cortex, which is where the cognitive functions are seated. So patients can develop cognitive complaints, sometimes even hallucinations if they are involving the posterior parts of the brain, etc. Now, there are two theories that you should become familiar with that are going to summarize this. Are the first theory, which is called body first, and the other one that is called brain first. And this is something that came up very recently. If you see the citation is from 2024. This is not 100% certain, but this is the closest we've gotten in terms of where is the disease coming from, where does it start, and how does it progress. So the body first theory says that everything starts in the gut. And that's why there's so many efforts in trying to do research in gut microbiota or inflammation in the gut related to Parkinson's. And it's that the protein starts becoming dysfunctional in the gut, and it goes up through the nerves and then it goes to the brain. So if this is the truth, you start seeing some clinical symptoms like constipation, changes in the heart function because it goes through the heart first, and then changes in gastric motility, and later it goes up to the brain. The brain first hypothesis says that it all starts near the olfactory bulb, so near the nose. And there are many theories of like, could this be an infectious agent that goes through the nose and then, like it causes inflammation and triggers this cascade of pathologic changes. And then it starts in the brain first and then goes to the body. And we still don't know which one. Maybe it's a combination of both. And then we have other techniques such as skin biopsy, cardiac biomarkers that allow us to determine which one is which in our patients. Now let's go a little back to understand the prevalence of Parkinson's, is why it's so important to us as clinicians and patients and community members to pay attention to this disease. This is the second most common neurodegenerative disease in the world after Alzheimer's. And we are expecting this to double its prevalence by 2050 because patients are living longer, because we're exposed to pesticides, because there are many different factors that continue to be present and makes us vulnerable to developing Parkinson's disease. So I'm sure we have people from everywhere in the US in this call, but I focused on the people from Indiana, Ohio, and Kentucky, and you can see that we have a good amount of people with Parkinson's. By this survey was from 2018. So imagine how much it could have changed in the last 8 years. But in Ohio only, almost 40,000 people with Parkinson's disease, and the economic burden, of course, is way high because it doesn't only quantify the amount of healthcare resources that are allocated for medications or appointments with the clinicians, but also how much this disease can impact a patient's quality of life, their capacity to work, to be independent, and continue to be engaged with the community. Just going to take a break here, a mental break for everyone, because we've talked about many important concepts. I wanted to share this photo. You guys should be very proud of your Haleakala National Park in Maui. So whenever you have a chance to visit, this is a great hike. You don't have to hike it all the way. You can drive to the peak. And it's so peaceful and quiet. So if you ever need some break from the noise of the city, take a trip to Hawaii, and we'll make sure you have enough levodopa to make it all the way there. So what are risk factors for Parkinson's? There are so many things, but I want to focus on this one. The first one is traumatic brain injury. We know that repetitive hits to the head can cause inflammation in the brain and trigger any sort of pathogenic cascades that can develop. It can go into causing, for example, frontotemporal dementia, but also Parkinson's disease. One example of that is boxing. Not the type of boxing you guys do in Parkinson's, because that one, the Rocksteady boxing program, we're going to talk about it, is very safe. No one's hitting anyone in the head, but the people who go and hit their heads constantly, they're at risk of having Parkinson's. And one example is Muhammad Ali, who developed Parkinson's, and probably secondary to the repetitive trauma in the head. The second image is way more troublesome to me because pollution is really impacting our patients in many different ways. And one of them is Parkinson's. And connected to that, there's a study that was recently published trying to link proximity to living close to a golf course with an increased risk of Parkinson's disease. The theory from these authors was that the pesticides they're using to treat the grass in the golf courses are getting either into the water in the neighborhoods or spread through the air, and patients are getting exposed to these pesticides that are toxic. If you look back at the Roundup or glyphosate, which are used to
yeah, no Parkinson's.
So these pesticides that are used to treat crops in every parts of the world, we know that they're associated with cancer, and now we know they can be associated with increasing the risk of Parkinson's disease. Now, take this with a grain of salt. Like, it doesn't mean you don't have to play golf. I always ask my patients, like, do you play golf? But just to bring this study to the conversation, but we just have to continue to see more research in this field. But at least we're getting some hints that there is a possibility that environmental factors are increasing our risk of developing Parkinson's. There are other factors like genes. People always ask us, can this be genetic? You know, my dad had Parkinson's, my brother had Parkinson's. I want to make sure that this is not a gene because I have children or I'm planning to have children, and I don't want this to be passed to the other generations. So to answer the question overall, it is less than 4% of cases when a gene is the cause of Parkinson's. And that is usually when the disease starts very early. So in the early 40s or earlier than 40 years old is when we start looking for genetic causes. So it really is not that prevalent. I would encourage you to scan this QR code, though. There is a project that is running in the United States, but of course we are a site here in Cincinnati that is called PD Generation. and it is testing 21 genes for patients with Parkinson's. This is totally free, no needles involved. All you get is something on your skin that is draining the blood from the capillaries. You can get it done during their next clinical appointments. And it gives you the result in case you're a carrier of one of the genes that could be associated with Parkinson's disease. This is a great book that was recently published by Dr. Michael Okun. I have my copy here that I carry with me when I travel because it's amazing, and it tells you about all these theories from environmental factors that could be associated with Parkinson's. And that's what they call the Parkinson's plan. That is not about just understanding the disease or what causes it, but what are we going to do as a society to try to decrease this? So they tell you about water, about food, about sports, about everything that you need to know that could help you prevent, delay, or as a community in general, try to stop Parkinson's from spreading around. This one is very close to all of us, especially after the pandemic, and people have not paid enough attention to loneliness. And loneliness is different to being alone, because you can have people around but still feel lonely. And that's why these support groups and like what we're doing right now become so important. When people feel lonely and they're not engaged and they're not cognitively active, that contributes to higher progression of neurodegenerative conditions, including dementia, including psychosis, including things such as depression. So they've done studies in the US and in the UK, and both studies confirm that people who are lonely or feeling lonely, their disease progresses much faster, and they're at higher risk of developing cognitive complications of their Parkinson's disease. So now going to the things that we can do to try to prevent Parkinson's from happening early or from happening at all. The first image is very controversial, and we as clinicians will never tell a patient to smoke, but some studies have shown that exposure to the carbon monoxide in the smoke, not to the other millions of toxins that are present in tobacco, but the carbon monoxide itself might have an anti-inflammatory response in patients with Parkinson's, to the point that it might delay disease onset or decrease the severity of the symptoms. So taking that into account, they came up with this clinical trial that is enrolling patients right now called Locomote PD, or low dose carbon monoxide trial, to evaluate the safety, tolerability, pharmacokinetics, and biomarkers in Parkinson's. So all people are doing is they're just drinking liquid carbon monoxide at small doses, and we're still trying to see what that does in Parkinson's patients. So this is still under investigation, but I wanted you to be aware that this is where the field is moving towards. The second one is caffeine, and we've had so many publications telling us coffee is good for your body. Coffee, of course, not in excess, but if you drink coffee, your risk of getting Parkinson's, your risk of getting intestinal disease is lower. And the third one, of course, is exercise. That is something that we encourage every one of you to do as much as you're capable of, but around 100 to 150 minutes of cardiovascular exercise per week is encouraged. During the winter, it's a little challenging because people cannot go out, walk their dogs, spend times in the park. But as much as you can do, if you're doing 0 today, doing 10 minutes tomorrow, it's a step in the right direction. So if we ask you to do 150 minutes, that's probably too much, but start slowly and start doing as much as you can. We have structured programs for exercise in Parkinson's disease, and they're available to the community. Here in Cincinnati, I've heard very good things about the Blue Wash Center for Parkinson's, but we also have physical and occupational therapy facilities in our institutions, in Cleveland Clinic, in the University of Cincinnati, and Columbus, also in Kentucky and Indiana, that can that allow you to participate and be engaged in physical activity. This QR code will take you to the Rocksteady Boxing website, where you can see facilities located near your home that are providing these activities for you. This is another photo. I'm from Colombia originally, so I wanted to share with you Cocora Valley, which is beautiful part in the coffee region, where we have the tallest palm trees in the world, or that's what I've been told. So if you ever have a chance to visit, I would encourage you to do so. So now let's go to understand what are we looking for when someone comes and asks us about, do I have Parkinson's? What are we as clinicians looking for? So the motor manifestations of Parkinson's are encased in these three or four words. The first one is Parkinsonism. When you hear us say Parkinsonism, it is just an umbrella terms for the constellation of symptoms that someone with Parkinson's can have. So Parkinsonism just means looks like Parkinson's, because there are many things that can look like Parkinsonism. For example, if you overdose on medications for nausea, you can develop Parkinsonism. That doesn't mean you have Parkinson's disease, right? Now, for Parkinson's disease, you need to have first bradykinesia. And what that means is that your movements are slower and the amplitude of those movements is decreased. And the way we test it in the clinic is we ask you to do the finger tapping. So a normal finger tapping, you see, it doesn't get slow and the amplitude is normal. But with Parkinson's, the amplitude starts going lower and the velocity is also decreased. And that is what bradykinesia means. The other feature is rest tremor. But remember, there are patients with Parkinson's who do not develop tremor. So you need to have bradykinesia, but tremor might be present or absent. And if tremor is present, it needs to be asymmetric, meaning our patients would tell us it started on the right side or it started on the left side, but not both at the same time. If tremor starts on both sides at the same time, we might feel that maybe we're not dealing with Parkinson's disease. And the third one is rigidity. The way we test it in the clinic is we take your arm, your elbow, and we start moving it. And this is, you're going to hear us saying, please relax, please relax. And it's so hard to relax in the clinic, but try to do it as much as possible because we're trying to see how much resistance to passive mobility we're getting. And that can be present in patients with Parkinson's. One of the manifestations of rigidity, if maybe some of you have experienced it, is shoulder pain, because that rigidity can impact any joint, especially the shoulder, and that can feel like frozen shoulder, which is sometimes very uncomfortable. Now, there are some red flags, as I mentioned. One of them, for example, is tremor is symmetric, starts on both sides at the same time. But another red flag is gait troubles very early in the disease, especially if it takes you to need to use a wheelchair very early. That is not common in Parkinson's. The other thing is absence of progression. This is a neurodegenerative condition, so we expect it to progress. Every patient is different. Of course, for some, unfortunately, it's faster, but for some, it is a very slow progression. And I would say for the majority, it's kind of in between. But if we don't see progression, hopefully that's because we're just treating you just perfectly, but we still can see some progression. The other thing is early bulbar dysfunction. So the bulb is this lower part of the brain, like you remember the broccoli, so the lower part of the stem, that is hosting swallowing function, speech. If those are affected very early in the disease, then that's probably not Parkinson's. There is a Parkinsonism syndrome that we call multiple systems atrophy that can cause what we call stridor. So we ask our patients, has anyone ever seen you sleep? And when you're sleeping, do you make weird sounds with your throat, kind of like you're having trouble breathing? If that is present, that is a very big red flag. That is probably not typical Parkinson's, but an atypical Parkinsonism, such as MSA or multiple systems atrophy. Severe autonomic failure, like you feel very lightheaded when you stand up. We call that orthostatic hypotension, or urinary retention or urinary incontinence. If they're present very early, those are red flags.
It's like us, he lives in the woods. Can't see his fucking things.
So recurrent falls, and then anterior-collis, meaning your neck bends all the way forward. So those are all things that we try to take a second look to, because we might not be dealing with just the typical Parkinson's disease. Now, other concepts that I want you to be familiar with are on, off, and dyskinesia. So when our patients with Parkinson's get their medicines and they feel that they kick in and they feel that they're better, we call that on. It's like switching the light on. But when the medication effect goes away and the symptoms for Parkinson's are coming back, we call that off. And there is another concept that is called dyskinesia. Dyskinesia just means abnormal movement. And it's not the usual tremor. It usually presents like what we call chorea. It's like dancing movements, purposeless, random. You cannot predict what the next movement is going to be. They can involve the torso, the arms, the legs. And that is a sign that the medication kicked in. It is a sign that the medication is working, but maybe it's working too much. We are causing excessive movement. So because patients with Parkinson's are not moving enough, we're giving them medicines to move a little bit more, but maybe now they're moving too much. And this can be a side effect from the medication, but also becomes more frequent as the disease progresses. So in later stages of Parkinson's, after 5 to 7 years of having Parkinson's, your chances of having dyskinesia are higher because the therapeutic window, meaning the amount of levodopa we can give you before you develop dyskinesia, becomes too narrow. So we need to make very, very, very fine titrations of the dose of the medication. So here we can see in this graph what happens usually when you take a medicine. So when you are not taking any medicines, you're off. And sometimes some of the manifestations of that off is what we call dystonia, meaning painful contractures of the arms, of the hands, of the feet. So those can happen. Once you take the medicine, then the concentration of the medication starts going up, and then it peaks. And now you feel better, but you can develop dyskinesia, and you only took a dose. So of course it is expected that the medication is going to be eliminated from your body. So you're going to go back to that off. And that is the continuum in Parkinson's, trying to be in between too much on and off, trying in the middle. So that's where we start seeing some fluctuations that we call on-off fluctuations. There are some non-motor symptoms for Parkinson's, of course. The first ones are going to be cognitive or behavioral. So patients with Parkinson's can have anxiety, can have depression, not only because of getting the diagnosis, but it just comes as part of the disease. And I encourage you to be open to your clinicians, with your clinicians or your family members, and tell them when you're not feeling well. This is very important because the burden of the disease can be shared. It doesn't have to fall on yourself only. And we know that having Parkinson's can be sometimes very distressing. And we have days that are very good, but also some days that are not too good. And we have things that we can help you with so that you don't feel, as I tell my patients, there is no reason for you to feel miserable. We have so many things that we can help you with. Apathy. So sometimes maybe you don't want to go to the movies, or you don't want to do anything. You want to stay on the couch. That can happen, and it's normal. But again, if we talk about it, we might be able to fix it. Frontal executive dysfunction. What that means is as the disease progresses, and as we said, it starts from the bottom of the brain and it goes all the way up, then you might start having some issues with planning tasks, multitasking. And at the end, like later stages of the disease, you can present with dementia if it's too advanced, and psychosis, which is our patients can complain of hallucinations, which can be visual or auditory. And I wanted to bring an important point here because this is something that is very common in patients with Parkinson's. Psychosis can be a part of the disease itself, but it's also triggered by the medications we use because dopamine promotes psychosis. Our patients with Parkinson's can start having what we call kind of like pleasant or non-bothersome hallucinations. And I've had patients who say, my hallucination is I listen to church music in the mornings. It's like this beautiful choir, and I hear it and I like it, so it's not bothersome to me. But once that is present, it means that your brain is in the capacity to develop hallucinations that can be more scary in the future. So I would encourage you to pay attention to those, even those hallucinations can be pleasant. We've had patients, for example, I had one of my mentors back in Houston where I trained for residency would say, one of the patients thought that the wife was an imposter and she was in the couch and he shot her with a gun. So it is very important to take care of these things because they can become violent. So once you're having some hints of my brain is processing things not the way it's supposed, please talk to your clinician because that can be the opportunity for us to start treating it before it gets worse. Now, sleep issues can be present in Parkinson's, sleep fragmentation, and not only because you're going to the restroom 5 times per night and that's what keeps you awake, but also Parkinson's itself can make your sleep shorter. There is something that we call REM behavioral disorder, which is you have 2 stages in sleep. We call it REM and non-REM, and REM means rapid eye movements. So there is a stage in sleep when you're dreaming that your eyes are moving back and forth. So that's what we call it rapid eye movements. or REM. And the REM behavioral disorder means that you're not only moving your eyes, but you're also kicking and punching, and that can hurt you yourself or hurt your partner who's sleeping with you. And I had a patient yesterday who told me, now we have 2 queen beds because I'm kicking my wife when I'm sleeping. So that can be very bothersome. That can be present in Parkinson's, but we have treatments for that. So just let us know. RLS is another uncomfortable sensation of your legs before bedtime, usually, that makes you want to move your legs before, so to get some benefit and feel better. And of course, if you're not sleeping well during the night, you're going to have daytime sleepiness or somnolence. As we mentioned before, orthostatic hypotension can also be present. So if you stand up quickly and you're not drinking enough water, your blood pressure might not regulate quick enough to bring blood to your brain, and you might feel that you're going to faint. Constipation, which we need to treat aggressively with water, with fiber, with laxatives if needed. We don't let our patients in our clinic wait for more than 2 days before having a bowel movement. If your stools are sitting in the intestine for too long, they're going to start pushing out to the walls of the intestine and create pouches that we call diverticula. Those diverticula start collecting bacteria. They get infected and inflamed, and that's what we call diverticulitis, to the point that they can rupture. So imagine your intestine having a hole and your stools going inside of your abdomen, causing a catastrophe. So you can even require surgery. So if we can prevent that and treat it aggressively, that's the way to go. Urogenital dysfunction. So patients with Parkinson's can complain of erectile dysfunction early in the disease, but it can also have urinary retention or incontinence. We have treatments for that. And changes in taste of smell that, remember, can happen even decades before the disease starts. There is something that a speech therapist showed me at one of the Parkinson conferences. I've recommended it to some of our patients who, for example, have they don't tolerate citrics or very strong acids or things like that. They're called the miracle berries. And if you have one of those berries, you can get them on Amazon. If you eat one of those before your meal, the things that usually taste disgusting or too strong might taste better. So they would just give us these very bad lime first. And of course, we're all making faces like, oh, this is too acid. After getting the berry, it tasted wonderfully. So if this is something that you're dealing with, you can give it a try. This is so every year as a rite of passage, we movement fellows go to Aspen to learn about Parkinson's and other things. And this was in the Maroon Bells last year. It's a wonderful hike. It's very flat, really not super challenging. It's a beautiful place. If you have the time and the opportunity to go, I would encourage you to do so. Okay, so now that we know clinical signs and symptoms of Parkinson's, how do we diagnose this? And this is an important question because as patients, we're always waiting for proof, right? We're always waiting for objective evidence that what I have is what my physician is telling me I have. So I want to see a lab test. I want to see an MRI that supports what the clinician is doing. It kind of looks like, how can you diagnose Parkinson's only by looking at me and making me tap my fingers? Like, how is that possible? So the first statement is the diagnosis of Parkinson's is clinical. We can do it in that visit when you go to the clinic because we don't need specialized imaging to do the diagnosis in most cases. There are some cases that are very special and challenging, and for those, we have some ancillary studies that we can support ourselves in to make the diagnosis. But overall, this is a clinical diagnosis that requires slowness of movement plus stiffness or tremor. Now, there's some other things that we can do. One of them is a skin biopsy. So this is called a punch skin biopsy. We take samples near your ankle, near your thigh, and in the back of your neck, and we send them to the lab, and it's going to tell us how much of that protein that we mentioned initially, called alpha-synuclein, is present in the skin. It is not specific for Parkinson's. We can see it in alpha-synucleinopathies. In other diseases that look like Parkinson's, this test can be positive. So it is not fully diagnostic of Parkinson's, but it allows us to get closer to the diagnosis whenever there is doubt. The second study is this one on the right that is called a DAT scan. DAT goes for dopamine transporter, and you know dopamine is the substance that is not made in enough amounts in patients with Parkinson's. So all the scan is doing or showing us is how much of that dopamine is getting into the brain. So in panel A, you see these two bright coma-shaped like images that is showing us the basal ganglia, which is, it's just showing us the dopamine is active in the whole structure on both sides. That's how it would look normally, like a nice coma. On the right, panel B, we're seeing a patient with Parkinson's disease. So you see that the tail of that coma disappears and it starts looking more like a dot. And if you are detail oriented, you'll also notice that the spot here on the left is brighter than the one on the right. So that is the asymmetry that we look for in Parkinson's. One side is more affected than the other. So this is something that we can see in Parkinson's patients. But again, this is not specific for Parkinson's. You can have a stroke in that specific part of your brain, and that's going to make that image blurry. Or you can have the other alpha-synucleinopathies that are going to make the DAT scan also positive. So we all need to take these tests within the context of the clinical findings and the clinical history. If you want to expand more on these, Michael Okun, who is the same person who wrote the Parkinson's plan, has this very nice kind of like a blog post called "Do I Need a Skin Biopsy or DAT Scan for My Parkinson's Disease?" So it tells you what are those specific scenarios when your clinician might want to ask for these tests. So if you scan the QR code, it's going to take you directly to that website. Okay, so this is again Colombia. This is Tayrona Park in the Caribbean. It's beautiful. It's a hike that takes you from transitions from the jungle where you can see monkeys and other some sorts of animals, and then you go to the ocean, and then you go back to the jungle, back and forth. So it's beautiful. Put it in your how do you say it, on your list of to-do things for this year or next one. Don't miss it. It's a great hike. So now, how do we treat Parkinson's? The first thing I want to emphasize is non-pharmacological. Our colleagues with physical therapy, occupational therapy, and speech therapy are our heroes, and they really help us a lot, not only because of keeping you engaged and active. Remember, loneliness is not a good thing in Parkinson's, but because we know that these therapies really make an impact in our patients. One of the things that we see sometimes is, for example, my insurance only covers 8 sessions per year, or if I'm doing physical therapy, they will not cover speech therapy. So we have fixes for that. One of my favorites is this one. It's called the Parkinson's Voice Project. I don't know if you're familiar with it, but it gives free speech therapy for patients with Parkinson's, and it's all virtual. If you scan the QR code, they have live sessions on Tuesdays, but they also have recorded sessions. You can practice and speak loud at like the LSVT therapy that we're trying to have our patients to speak a little louder to try to avoid that hypophonia. This is a great resource for patients who do not have access to speech therapy for whatever reason, or who want to do it from the comfort of their homes. For physical therapy, as we said, we have guided physical therapy that is geared towards helping with gait and balance, but also the rock steady boxing. There's also yoga, tai chi. You can do it from a chair if that's important for you in terms of you don't feel too steady. And of course, diet. We have a nutritionist in our clinic that is dedicated to patients with Parkinson's. There's always a concern about protein intake and its interaction with the medications or weight loss. So they are really good at giving you the guidance that you need to not lose a lot of weight, to keep your muscle mass. Remember, muscle mass is important to prevent falls. And there's so many other resources from the Parkinson's Foundation, the Michael J. Fox Foundation, and the Sunflower Symposium that you get to learn, meet other people. The Cincinnati Ballet came last year. They did a wonderful session. They have therapies, dancing therapies for patients with Parkinson's. Now let's go to the science, which is the medications for motor symptoms. So first, let's describe or define 2 terms. First, dopamine agonist. Dopamine, which is the molecule that helps us move and that we're not making enough of with Parkinson's. And agonist means acts like it. So acts on the dopamine receptors and activates them. And an enzyme is a protein that is inside of your cells that is either going to destroy or allow that medication to stay for longer. The definition is a protein that changes the structures of other proteins or molecules, even medications. So here we see the main medicine or molecule we use for Parkinson's is called L-DOPA or levodopa. there's an enzyme called dopa carboxylase that converts this levodopa into dopamine in the brain so that it can go to the basal ganglia and help you move. But you see here this word carbidopa. Carbidopa also comes with your medication. If you read the name of the medicine, it's called carbidopa levodopa. What carbidopa is doing is blocking this enzyme so that levodopa doesn't get converted too quickly. Because if it does, then it's going to start acting in your gut, in your stomach, and that's when you have nausea or gastrointestinal side effects. That is the main thing that our patients complain of when they take levodopa is, oh, I'm feeling nauseous. So we ask them to either take a snack, like a piece of bread, crackers, orange juice with the medicine, or we can increase the amount of carbidopa so that it can protect the medication to not be converted before it gets into the brain. So let's talk a little bit more about dopamine agonists. These medications were popularly used before because we had a thought that maybe we needed to reserve that levodopa or carbidopa levodopa to the later stages to not cause complications and maybe to not steal our patients the chance of having that as a last resort before they develop more bothersome symptoms. But now we know that is not true. When we were practicing that way before, all we did was taking away lives of good quality from our patients because we're not giving them the medicine that they needed, which is levodopa. We still, in some cases, use dopamine agonists, especially in patients who have restless leg syndrome. That is a medication that we can prescribe. Or in patients with Parkinson's that is very mild, or that patients are having hallucinations or things like that, that we don't want to worsen with levodopa. We might prefer some of these medicines, but overall, that is not something that we would prescribe initially. It is important to identify that these medicines work in other receptors that we don't want them to work on, some other dopamine receptors. So patients can have impulse control disorders, like going to a casino and spending all their money, or shopping, spending $2,000 in clothes the night before. I had a patient who said, I spent $5,000 on Christmas decorations. And I said, you know what? I don't blame you. I would probably do the same, but maybe there is a moment in which too much money becomes too much money and it's troublesome. So we try to stay away from these medicines. The only one that I want you to pay attention to is apomorphine, which is on the bottom of the list, because that is a medicine that we can use to treat intermittent off symptoms. This is not like levodopa, but it comes as an injection and it also comes as a pump, and we're going to talk about it later. There's some enzyme inhibitors that can make us help us make the medications last longer. We call them COMT inhibitors or MAO inhibitors. Your physicians might prescribe them or not. These come only as tablets. There's one that comes as a patch, which is actually these all comes as come as tablets. And all we do is try to prolong the half-life of the levodopa that is in your system. We try to use them with caution because they can increase the amount of dyskinesia, and at least some of them, entacapone and opicapone, can cause trouble in the liver. So we need to be very careful with those medications. So now going back to the main, the protagonist of the whole Parkinson's disease treatment, which is levodopa. So your medicine will say carbidopa, levodopa, as we said, but we're going to refer to it as levodopa because that's the active component that we want the brain to take. It comes in different formulations: immediate release, controlled release, and there are new technologies like Rytary and Crexon. I want you to see this graph because it allows you to understand how those different medication forms act. So if you look at the light blue light, that is the regular carbidopa, levodopa, immediate release, or Cinemet. When you take the medicine, it peaks maybe 20 to 40 minutes after you take it. So that's why it's called immediate release. It kicks in. But then very quickly afterwards starts going down. So the concentration of the medicine is going to go out of your body very quickly, and it will not last more than 90 minutes. So that's why you have to take this medicine at least 3 times per day when you start taking it. But we have patients who end up taking it every 2 hours. This medication, when it starts wearing off, the dopamine that is in your system is the one that your brain's still making. So that's why we need to supplement you with more dopamine. Then the controlled release formulation is the red one. It doesn't have that kick-in effect. It doesn't have the immediate release form. It's more controlled release, so it takes a while before it starts acting, and then it stays in your body for a little longer. But this CR formulation has a very variable absorption or like half-life. So that's why we don't like to use it during the day. You'll see us using it during the nighttime because then we are more confident that when you're taking it at night or before bedtime, you're going to have some residual levodopa in your system so that you can reach for the blanket without difficulty or turn in bed without feeling stiff. Or if you're going to go to the restroom, you have some medication still in your system so that you can walk without risk of falling. But you'll see sometimes if we use it during the day, is because the insurance companies are asking us to do so before they can approve the other forms, which we don't like to do. We know it's not going to work, but sometimes that's what ends up happening. So now look at the table comparing these formulations. So the Cinemet IR, as we said, is the one that kicks in, but we have to dose it maybe 3 times a day or more. Then the Cinemet CR is the one that is controlled release, and we tend to use it mostly at bedtime. Rytary is it's a technology or a capsule that has been available for many years, and last year it became generic. So it's giving us some trouble because the insurance companies are covering only the generic form right now, and it is a little bit confusing. Rytary, within the same capsule, has both forms of Cinemet or levodopa, the immediate release and the extended release. So it kicks in and it also lasts longer. There is a newer version from the same company that is called Crexon. It also has, within the same capsule, the immediate release and the controlled release formulations, but these granules now have a mucoadhesive polymer, meaning that the little granules are going to stick to the duodenum, which is the first part of the intestine, and they'll stay there for longer, releasing the medication more steadily. And it doesn't matter if you eat or not, because the medication will stay there. So it's not competing with protein, it's not causing issues. So we like it a lot. And now it's becoming a medicine that we prescribe very frequently. Now you would say, why do I need to use Cinemet IR before I use Crexon? Like, why don't I just start Crexon from the beginning? Of course, there are some financial limitations for that, but also you might not need it, right? So Cinemet IR might be the medications you need initially, and you might just do very well with that. The extended release formulations, we're going to keep them for more advanced stages of the disease when you're starting to take medications too often or when the medicine is not lasting enough after you take it. The only caveat with the capsules, of course, is that you cannot break them. The Cinemet pills, we use them to titrate because we can break them in halves and quarters. So it allows us to make a finer titration. The capsules, we need to just prescribe a different strength to try to play with the doses up and down. You cannot break them. Now, some of our patients say, I'm feeling great throughout the day, but I have these very infrequent times in which I feel that the medication doesn't kick in. And we call that infrequent off. For those, we have as-needed medications that we can use. One of them up here in the upper left corner is called Inbrija, which is an inhaled version of levodopa. So this is the inhaler, and you have to put 1 capsule at a time, a total of 2 capsules, and crush them. So it releases the powder, and then you inhale that powder, and it works. It gets absorbed through your lung capillaries, blood vessels, and it goes all the way up to your brain very quickly in about 10 to 15 minutes. Some patients don't like it because one of the main issues is cough. The powder makes you cough. If you have asthma, for sure, you're just gonna irritate your airway. And then the other thing, it changes the color of your saliva, of your sputum. It makes it a little darker. It's not life-threatening, but it's important for us to tell you so you don't get worried when you see that your saliva is darker. There's another one that is called Nurians, that it comes as a pill. We still don't fully know how it helps people with Parkinson's, but it has a similar mechanism like coffee. So some of our patients can use it as needed for off symptoms. This one is like an EpiPen, and it's called Apoquine. Remember, we talked about apomorphine, like one of those dopamine agonists. So Apoquine is a prefillable syringe that comes within a pen. So you can just inject yourself in the thigh when you're having off symptoms, and you can use it up to 5 times per day. And the only thing is that it can cause nausea. So we need to make our patients aware of that limitation. But overall, it works very well for those off symptoms. Now, the technology has advanced tremendously. And I know that our patients end up, unfortunately, planning their days around the pills, and they have to set up alarms to take pills all day when they become so frequent. So thinking about that, our colleagues from pharmaceutical companies have developed what we call continuous infusions of levodopa. The one that has been in the market for a long time is this one called Duopa, or levodopa intestinal gel. That one was used a lot because it would allow for a continuous infusion throughout the day and replace the pills that you were taking 2 or 5 times per day. But the only thing is that it required a G tube to be placed. So it was a surgery. So you need to go to the gastroenterologist or to the surgeon and get a tube placed on this through the skin directly to the stomach, and then infuse the medication through that tube. So that was a little scary to some of our patients, and we totally understand that having a G tube, even though some patients do it perfectly fine, for some it might be a little scary. So we're now more advanced in that regards. And now, as patients with diabetes have insulin pumps, now we have levodopa pumps that go through the skin without the need for surgery. And those are the subcutaneous infusions of levodopa and also apomorphine. So the same injectable Apoquine also comes as a pump that you can use. But that apomorphine infusion does not replace the oral levodopa. But the levodopa pumps, like the ones on the right, like Vyalev, they replace the pills, or that's overall the idea. So you're getting this infusion throughout the day, even when you're sleeping, and it's a constant rate. I always tell my patients, your brain is not making dopamine at, if you take levodopa at 6, 12, and 6, your brain is not making dopamine at 6, 12, and 6. It's making dopamine continuously as a response to your needs, to your movements, to your stressors, or whatever. So this is the closest we've gotten in terms of giving the brain what it would do, which is a constant rate of dopamine throughout the day. We can tune in those very finely in terms of milliliters per hour. Is a very, very small amounts that we can titrate. So it allows us to prevent dyskinesias as well, or motor fluctuations. These are very promising and we like them a lot. Some of our patients are choosing them. Of course, it is important to understand that we need to take very good care of the skin. If you don't clean it well, you're prone to infections. And also the medication can infiltrate sometimes under the skin and create nodules that are not life-threatening, but it's more a cosmetic side effect that you can see some nodules under the skin where you place the cannulas. But this is a very good option for patients who are taking too many pills per day, who are interested in getting a continuous infusion, and who are not yet ready for what we're going to talk about, which is deep brain stimulation. So advanced therapies for Parkinson's are deep brain stimulation and MRI-guided focused ultrasound. So on the left, we're seeing deep brain stimulation. Deep means that we are stimulating the deeper parts of the brain, which is where the basal ganglia, and that's where the electrodes are going. So what we do is we implant we can do it one side or both sides at the same time. So electrodes inside of the brain, they're covered under the skull, so you don't see them. No one can tell that you have this when you're walking in the street. And then we connect the electrodes with a cable that goes under the neck, under the skin, which also not noticeable. And then we place a battery near your chest, kind of similar to a pacemaker. And that's called the pulse generator. That is what's going to send the signal, the electric signals to the brain so that we can modify the activity. This is very helpful. It's overall a very safe surgery, but less than 10% of the patients that we refer for actually end up getting it for several reasons, because we want to make sure that we follow the protocol strictly and that the patient that we send to the OR is the best candidate for it. When you choose to go the DBS route or deep brain stimulation route, we ask you to go to a neuropsychologist and get full testing, because dementia is probably a contraindication for it. Patients who have cognitive impairment can get worsening of that cognitive impairment with deep brain stimulation. So we want to make sure that that's not the case. Also, we ask you to get a brain MRI so that, of course, we can plan for the surgery, but also make sure that we're not missing anything. And you also need to see a neurosurgeon. So by the time you decide to move forward with this to the surgery, can be between 6 to 12 months. It's a process. And we present all this information in a meeting, a clinical meeting that we have with all the physicians from the division to make sure we discuss each case with detail before telling if you're a good candidate or not. But if you're a good candidate for it, this is a therapy that can be very impactful. The surgery starts, it can be done awake or asleep. It depends on the patient's preference. But our preference sometimes is to do it awake, because they sedate you in the initial part, then you wake up. While you're awake, we can test the tremor, the slowness, everything, and adjust the parameters in the OR to make sure that we are targeting the place that we're supposed to and give you the best benefit without causing too many side effects. So that's why we try to do it awake. The other therapy is MRI-guided focused ultrasound. So some patients are not good candidates for DBS because they're on anticoagulation, because they're high-risk cardiac patients, so anesthesia will not let them go to the OR or things like that. The risk of getting surgery is too high. So MRI-guided focused ultrasound is not surgery per se, but it doesn't mean that it's not invasive. So it's less invasive, but all we're doing is using an MRI. Patients are going to wear a helmet that has a cooling water system inside so that we don't cause too much issues on the scalp, or we don't heat up your head too much and burn your skin. And we use these ultrasound waves and focus them on one single point that we know is going to take care of the tremor or the symptoms from Parkinson's disease. That is something that is ambulatory. So you just go one day, you get it done, and then you're out. The issue is, of course, it's a one-time thing. You can do it again, you can repeat it, but we cannot change the stimulation parameters as we would do in DBS. So with the MRI-guided focused ultrasound, you get the lesion, and the benefit you got, that's what you got. And then with time, the brain might regenerate, so some of the symptoms will come back, and that's when you might need a second procedure. It doesn't come without risks, of course. The risk of bleeding is very minimal, but there's some case reports of people who have had some small hemorrhages in the brain with this treatment. Now, these are frequently asked questions that our patients come up with in the clinic. The first one is going to be stem cells. Stem cells are available everywhere outside of the US. You can pay out of pocket. You can get infusions of stem cells for Parkinson's disease. The teaching point today is going to be, this is still undergoing research that is undergoing. We don't have approval to use this for Parkinson's. We don't fully understand the benefits or risks for stem cell therapy in Parkinson's or their use. There's some clinical trials that are showing that getting stem cells can reduce the motor symptoms in Parkinson's. But again, for us to be able to prove that this therapy is worth it and that is not, that the risks are lower than the benefits, is going to require more trials. So for now, I would encourage you to continue being aware of the research and reading the reports. But if you have colleagues or yourselves, you heard of any company that is promising you getting stem cells outside of the US, I would highly encourage you to try to avoid that for now. The second question is about cannabis. This is something that for some patients is helpful for anxiety, to help them sleep. But in Parkinson's, there is no strong evidence that it helps with motor symptoms, or even in some patients with Parkinson's, it can make their sleep worse or their mood symptoms worse. So cannabis as a therapy for Parkinson's is not something that we would recommend. The third one is a plant that is called Mucuna pruriens that some patients have read about. You can get it in the store. It has levodopa. It has dopamine in the plant. You know, there's an insulin plant where you can, I forgot the name now, but there's a plant, that moringa, that has insulin, and people tend to prepare, they make tea preparations from the plant to control their sugar. That plant will never be the same as the insulin that our companies make. The concentration of insulin is too low in the plant. You need to drink tons of tea to get a single dose of the insulin you get with an injection. It is the same with Mucuna pruriens or any plants that could have some concentrations of dopamine. You would need huge amounts of the plant to replace the pills that you're taking. And also remember that any supplement that you buy on the market is not regulated by the FDA. So the supplement can tell you that it has 100 milligrams of something. That doesn't mean it's true, because no one has proven that that is the case. So I would encourage you to not replace your medications from these other therapies because the efficacy might not be the same. The last thing I wanted to bring about is the newer infusion therapies, similar to the ones that have been approved for Alzheimer's dementia. There are some trials. One of the medications is called prasinezumab that is trying to clear the protein from the brain, the alpha-synuclein, thinking that that is what's causing Parkinson's, and that if we clear the protein, that the brain will regenerate and then your motor symptoms are going to get better. So far, the trials have failed, and they haven't proven that this is true. So infusion therapies for Parkinson's are not a reality as of today. And we have concerns that maybe that is not the right approach. So again, remain interested about research, about other alternatives, but take everything with a grain of salt. And I welcome you to bring all these things to the clinic so that we can discuss them together and you can make a decision based on the information that we give you. With that, I wanted to bring this last photo of Teotihuacan, which is the pyramid site near Mexico City. So it's not too far from us here. It's a beautiful sightseeing place, and you get to see the pyramids. And if you're adventurous enough, you can go into one of those hot air balloons. I'm not that kind of person, so I just took a photo from the ground. Now, I appreciate all of your time listening to me this morning, but I wanted to open it to questions and anything that we can help with.
Okay, there's one in the pool about people with diabetes have a greater chance of developing Parkinson's disease. Can you comment on that?
Yeah, so there are some links that, because you have a pro-inflammatory response in people with diabetes, having more inflammation can potentially increase your chances of getting Parkinson's, but it is not a certain 100% certain thing. And actually, it is in our clinic, we tend to not see people with Parkinson's with history of diabetes. It's actually kind of rare to see both at the same time.
And back to the infusions and the nodules, do they go away or do you just keep getting more nodules?
The nodules, unfortunately, might stay there for a while. The therapies have been approved in the US starting last year, the subcutaneous infusions. They've been approved in Europe for many other years. So we're still seeing what the long-term expectations are with these therapies in terms of those nodules. But again, it can be noticeable. It can be uncomfortable for some people, especially if you're going to wear swimming suits or something like that. So it might make you feel too aware of those, but again, they're not painful, they're not life-threatening. We care really more about the potential for infection if you don't clean the area well or you're not changing the cannula often.
I have a question. I've never heard of these miracle berries you talked about.
Yeah.
So is this for people who lose their appetite? They complain about a loss of taste.
So it is when we call that dysgeusia, which is when your taste is weird.
Okay.
So you're not tolerating spices, you're not tolerating acid things. So it doesn't increase your appetite. All it does is it improves the taste profile of the things you're eating. So you can eat one of the berries before and then just eat your meal and it might change your experience. So you can give it a try and see if it works for you.
Okay. There's a question about a copy of these slides. This will be put on the website in a few weeks. It takes us a few weeks to get it up there. So yes, there will be a copy. If you're experiencing some slight tremors occasionally, and a parent who had Parkinson's, but you're not having any other symptoms, would you recommend making an initial appointment?
That is a good question. I think it is important to establish care with your neurologist soon. Remember, motor symptoms are just one part of the spectrum. Non-motor symptoms can also impact your quality of life. And we as clinicians are able to help you with those as well.
And I would say, add to that, not just your neurologist, go to a movement disorder specialist.
Yeah.
they're going to be more astute in identifying your risk factors and tremors.
And also we have research going on. If you're interested, if the earlier you are in Parkinson's, that's going to be very helpful. You can become eligible for more other trials or could help us with other studies that we're doing to try to understand better this disease and of course impact the community.
Thank you so much, Jorge. We really have to wrap this up to get on to the next phase, which you're welcome to attend, but I know that you're busy. So I'm going to turn this over to Elizabeth, a person who has successfully lived with Parkinson's for more than 30 years now, Elizabeth? Or am I making you too old?
28.
28 years. 28 years and counting.
Yes.
All right. And she's going to invite some people with Parkinson's to share their story. And again, thank you, Jorge. I learned a lot today. I hope everybody else did.
Thank you
Yes,
all.
excellent. Thank you so much.
Thank you, Maureen. My name is Elizabeth Grover, and Dr. Patino has given us lots of helpful information about Parkinson's, and he knows a lot about the disease. But what he can't tell you is what it's like to actually live with Parkinson's. I am a PWP, that means person with Parkinson's, and I was diagnosed 28 years ago. Joining me today are Margaret Sheldon and Mike Land, who are also PWPs. We are each going to answer 3 sets of questions that will combine to tell our stories of our Parkinson's journey in a way that we hope will be helpful to you. The first set of questions is, what was your reaction when you were diagnosed? What were your fears and your expectations? And please also tell us when you were diagnosed. Margaret, you want to go first?
I'll go first. I was diagnosed almost 20 years ago, and my first reaction was disbelief, and then dismay, and then ultimately denial for a couple months, probably. I remember thinking I can't have PD because that's only for old men. Sorry, gentlemen. But I thought it was a disease that only men got. So I was diagnosed as I was finishing nursing school, and I was terrified that I wouldn't be able to work as a nurse or in any other occupation, and how would I support my family? I worried about what would happen to me physically. Would I lose all my independence? And so I decided I would just not tell anybody I had Parkinson's. I'll stop there right now.
Okay, thank you.
Mm-hmm.
Mike, what was your reaction when you were diagnosed, and what were your fears and expectations?
Sure. I was diagnosed in 2018, and when I was first diagnosed, it was also disbelief. I didn't know many people that had Parkinson's, so I didn't know a lot about the disease, other than I had a number of things going on with me, and I knew, something was potentially wrong. So when I was first diagnosed, I didn't know what to expect. I did a lot of research on my own. I did a lot of asking questions to doctors. I attended support groups. I tried to do all the things possible to get a better understanding of what to expect in the future, because I really did not know what my expectations of the future were going to be due to the Parkinson's. And I was very worried because I had, a family, 4 kids, and, I did not want to struggle the rest of my life. And it was very bothersome. But I found that there's it's not things are not always as horrible as they first seem.
Mm-hmm.
Okay. For my part, first of all, I did not expect to get Parkinson's. I expected to get cancer. There's a lot of cancer in my family. My mother and all three of her siblings have had cancer. My mother contracted breast cancer at the age of 28 and died when I was 6. Since breast cancer can be strongly genetic, I always expected I would get breast cancer. So when I was diagnosed with Parkinson's in 1998, I was said, wrong disease. I wasn't prepared for Parkinson's. I did, by the way, eventually get breast cancer. Naturally, I was surprised, but not completely shocked because both of my maternal grandparents had had Parkinson's. So my expectation was that I would be like my grandparents. My grandmother, who lived with PD for more than 15 years and died at the age of 90, was confined to her bed for the last few years of her life. My grandfather spent his last few years refusing to take his PD meds and shuffling around the house. They were, by the way, divorced long before either was diagnosed and never shared their experiences of Parkinson's with each other. So, because of my grandparents, I thought I knew a lot about Parkinson's, but it turns out, as I was diagnosed at age 39, I was considered to be young onset Parkinson's. People are young onset if they're diagnosed before the age of 50. And people with young onset Parkinson's tend to progress more slowly and sometimes have more or at least different complications down the road. So when I asked the doctor who diagnosed me what the prognosis was, I expected the worst. He told me that within each individual, PD tends to progress at a consistent rate, but that rate was different for every person with PD. So we would not know until I had been observed for a while what that rate would be for me. So instead of fearing the worst, I felt the fear of the unknown. Another expectation was that I would not be able to be a good mother to my 3 children, who were then ages 14, 12, and 9. At that point, I was a single mom, and as I did not know how quickly my abilities would decline, I again feared the worst. But my children were at least initially more of a help than a burden because of their attitude. Their reaction to my diagnosis gave me hope. My 9-year-old assured me that things would be okay. When I said I would miss things like taking my grandchildren to the zoo, she said, we can push your wheelchair at the zoo, and since you get a handicap parking permit, we'll even get the best parking place. Now that 9-year-old is 37 and has 2 daughters of her own, and I have indeed been to the zoo with my grandchildren. After she said this, I felt inspired to focus on how I was doing each day and not look too far into the future, because I realized that might be worrying about things that would never happen or things that I could deal with when they did happen. The second set of questions we're going to answer is, how has your PD progressed, and were your fears and expectations realized? Margaret?
Like you, I was early onset Parkinson's. I was diagnosed when I was 44, and I also have 3 children, and they were more of a help than anything else. But my Parkinson's has progressed very slowly. So I would say that my fears were not met. It hasn't been as bad as I thought it was going to be. Sorry. I was worried about my employment situation initially, but I was able to work as a nurse for several years. And I'm still physically active, and I try to challenge myself to keep on being physically and mentally challenged.
Okay.
That's it.
Thank you. Mike, were your fears and expectations realized? How's it happened with you?
No, as I said in the beginning, I was very nervous about what was going to happen, and I had, as I read about things, some of the things I read did not give a wonderful outlook on what could potentially happen down the road. So I was very nervous about things. I also was working. I was diagnosed when I was 52, um, and you know, I I really enjoyed working, and didn't want all the things that I had kind of envisioned in the future to change. Um, I do not have much of a tremor at all. Occasionally, I have a small tremor, but for the most part, I've got a lot of the other symptoms. The things that have been the bigger issues for me have been a lot of the non-motor symptoms, um, things that are often invisible to other people, but have caused a variety of issues for me. I will also say that one of the things that has stood out to me when as I've gone through, you know, 8 years of being diagnosed, is I had the expectation that things were going to go way downhill a lot faster, and you know, I I was trying to do everything I could to slow the progression, and um, fortunately, my doctors and people that I met were very quick to share things like exercise and things that would help me sustain um, in my current state as long as possible, and hopefully slow down the progression. And it's although there's been many challenges, um, I feel like I have been able to live much of the way I would like to live uh, with my Parkinson's.
Thank you, Mike. For me, every Parkinson's patient is different, so there's no guarantee, but really not even an expectation that your PD will act like mine. But I have found that my PD symptoms to be fairly manageable in a way I had not expected. I think that's similar to what the two of you have just said. The progression of my PD has been quite slow, so I've been able to adapt along the way. Some of my most troublesome symptoms are difficulty with walking and balance, and more recently, posture has been my most difficult symptom. I've adjusted to increasing severity of my PD symptoms by targeting those symptoms in my exercise routines, as well as working on them in my everyday movements. The posture issues cause a lot of pain in my back, so I incorporate back strengthening and stretching exercises into my PD-specific exercise routines. And when walking, I align myself with some straight vertical line in my line of sight, such as the edge of a window or a door frame, so that I'm working on straight posture. I'm trying to stand up as straight as I can. I've also started using a walker because it alleviates my back pain. The fact that it helps me walk much more easily is a bonus. It's been a challenge to keeping up with the large number of symptoms my Parkinson's exhibits, but I try to be aware of each symptom so that I can prevent them from taking over. Our third and final question is, what steps have you taken to manage your Parkinson's? Margaret.
I've really tried to stay physically active. And I've recently just started going to the Cincinnati Ballet Moves classes, which are so fun. And they're so good for you. I would encourage people to reach out to occupational therapy and physical therapy, speech therapy, because they too are so helpful. And I just last week started the boxing class, and that's really different and fun. And you also get some of the social support that you might need going to those classes. So I've done that. And I also underwent DBS. I almost forgot about that. I underwent DBS in 2023 with good results. A lot of my family and friends have said they've noticed an improvement in my symptoms. So that's an ongoing thing with trying to reach um, the right settings on my losing my mind. Trying to set what
Right
did you say?
settings for your stimulator.
It's my stimulator. Thanks, Maureen. So, but I really feel like it's been much more of a manageable journey than I thought it was going to be. Mike.
Great.
Yeah. So for me, I think, my biggest issues have been like you, Elizabeth, balance. Um, my posture is not great. I tend to lean forward, which doesn't help with the balance part of it. And then I've also had a lot of trouble with executive function of, I used to be able to multitask, or I always thought that I had this great memory, and uh, I can remember a lot of things that happened long ago. I just can't remember what I had for lunch yesterday. So, but the nice thing, the way I've managed things is I go to two gyms in the Cincinnati area, and we're very fortunate that we have the services that we have locally. I go to the NeuroFit gym and also a Forever Fitness, and in both of those places, they have exercises that help with balance. I do boxing, and we do a variety of different exercises for strength and for kind of things to look out for. Uh, Also, both of the places have cognitive function pieces added to it. I've also taken part in the Parkinson's Voice Project, which I was having a little trouble swallowing, and my doctor suggested that I do that, and it was uh, really it has been. I continue to do it. It's really a very good thing that's out there that has been helpful for me, and I know it's been helpful for a lot of people, and that's a wonderful service that um, is available. That's the other thing I would say is, we're fortunate that um, with Parkinson's, there are a lot of services that are out there, and a lot of it is just asking where and what is available. I know at the Parkinson's Support and Wellness website, there's all kinds of information that you can share that shares, where gyms are and where support groups are and things like that. And then, like Margaret said, I will have to say, one of the things that I was probably most worried about initially was just, how I would, if I would be telling people, or, what to expect. And the people that I've met at the gyms that I go to, both the teachers and the people that take part in the exercise classes, have been just probably the best part of Parkinson's. I don't know if there's a great part of Parkinson's, but these are people that I probably never would have met had I not been in the situation. And they've been a blessing to me in the sense that they've, helped me motivationally. They've helped me understand, some of the things that they've gone through, and they've just really made a hard situation a little bit easier. Um, so, uh, you know, uh, and then the only other thing that I would say, managing wise, I do try and listen to a lot of podcasts and things like that from the Parkinson's Foundation and Michael J. Fox and Davis Finney and all the other organizations that are out there, like Parkinson's Support and Wellness, because it is, information for me is something that always has helped me kind of plan for the future. And the more I know, I feel like the better prepared I can be for things that can happen.
Can I just interject there? Thanks for mentioning the Parkinson's Support and Wellness website, because there is a lot we have a post of all the exercise classes and support groups in the area. that website is parkinsoncincinnati.org, in case you haven't been to it. We welcome you. And then, as I said earlier, these PD EDU sessions are on the website as well, so you can listen at your convenience. Thanks, Mike.
Thank you, Maureen, and thank you, Mike.
Yes.
I agree with you about the people that we meet. My husband says only the nice people get Parkinson's. For me, what steps have I taken to manage my Parkinson's? For me, the first and most important step is exercise. When I was first diagnosed, I had a friend who set up walking buddies for me. And I tried to exercise 2 or 3 hours a week. Over the years, I added more and more exercise opportunities. I've done Tai Chi and yoga. I used to walk or hike almost every day, weather permitting. I attend Parkinson-specific exercise classes and work out 3 times a week with personal trainers who specialize in Parkinson's, and attend the PD-specific dance classes twice a week. Exercise makes my body produce more dopamine, gives me muscles, the strength. It gives my muscles the strength to combat the physical symptoms of PD. It improves mood, and the stretching part of the exercise helps combat rigidity. And research has shown that exercise is the only treatment, including all the many drugs you may be prescribed, the only treatment that can slow the progression of the disease. I truly believe that the reason I can manage my PD is that I have slowed its progression by exercising a lot. And when the rate of decline is slow, I can adapt along the way. I get used to each new symptom, and by taking them on one symptom at a time, one day at a time, I can deal with it. Another step I've taken is to learn as much as I can about PD, and that was also, Mike mentioned that. Information is important. I've attended conferences and webinars and meetings. I've read books and articles. I've worked to make information available for others with PD as well. This has led to me becoming involved in the Parkinson's community. My involvement in the local PD community has taken many forms. I served on the board of Parkinson's Support and Wellness for 17 years so far and counting. I served on the program committee for nearly 10 years. I've been instrumental in starting exercise classes and the Parkinson's singing group. I brought the Dance for PD program to our area. I started a program to meet the special information needs of the newly diagnosed. And I find all this community involvement very rewarding because it keeps my brain working, while at the same time sending me an abundance of gratitude and lots of socialization. It helps me stay connected with people. Keeping a social network, it was especially difficult during COVID times, so you can see the difference. But it's very important. A recent study that I think Dr. Patino mentioned actually found that the single best predictor of decline in Parkinson's was a sense of loneliness. Finally, though, is it easier said than done? I think perhaps the most beneficial step I've taken is my intention to keep a good attitude. Attitude makes a huge difference in the amount of stress in my life. When my husband and I first moved to our new senior living apartment where we live now, I often took the stairs to our 3rd floor apartment just for the exercise. I found the fire doors by the stairwells very heavy. At first I thought, oh, these doors are so heavy. Then I changed my tune and thought, hey, I'm strong. I am so strong I can open these doors. This change in attitude made it much easier to open the doors. Just believing I'm doing something proactive about my PD gives me hope that I can continue to stand up to this disease, and I won't let it completely control my life. So I hope that what we've shared with you has been helpful. We'll be happy to answer any questions if anybody has questions.
I'd just like to thank you, Margaret and Mike and Elizabeth, for doing this. It's very helpful, I think, for both people with Parkinson's and caregivers or care providers. Helps us get an insight to what you're going through. And thank you for all the work that you have done and continue to do. So if there's no questions, Thanks again for spending part of your Saturday morning with us. Get out there and enjoy the weather. It's currently 57 and sunny. And it might snow tomorrow, so get out there today.
Wash your car.
Yeah.
That's what I did.
All right. Thanks a
All
lot. Bye,
right. Bye-bye,
everybody.
everyone. Yep. See you soon. Thank you.